Ultrasound Forum Network Conference, focused on the role of the ultrasound in the prevention and control of the COVID-19. I'm Wei Zhang from the Ultrasound Department of the 3rd Affiliated Hospital of Guangxi Medical University. Please allow me to introduce the experts and speakers come from China. Professor Wen He, President of CUDA for Beijing Tiantan Hospital, Capital Medical University. Welcome. Yu Kunluo from the First Medical Center of the PLA General Hospital. Dr. Qing Zhou from the People's Hospital of Wuhan University. And Dr. Li Yuan from the Wuhan Children's Hospital, Hongji Medical College, Huazhong University of Science and Technology. Dr. Xiang Fei from the First Medical Center of the PLA General Hospital. Dr. Meng Wu from the Wuhan Leishenshan Hospital. Dr. Qu Yali from the Wuhan Jinyintan Hospital. Dr. Mingbo Zhang from the First Medical Center of the PLA General Hospital, and Dr. Teng Feiyu from the Beijing Tiantan Hospital, Capital Medical University. Welcome. And among them, Professor Qing Zhou, Li Yuan, Ya Liqu, and Meng Wu are from Wuhan, which is the most severe area of the COVID-19 in China. In the past 2 months, they have been worked on the front line and made a lot of contribution to fight the epidemic. Thank you very much. And now, let's invite Professor Gao from the AIUM to introduce the expert from United States. Professor Gao, it's over to you, please.
Good morning, everyone. It's my great honor and a pleasure to be here today to introduce my dear colleagues at the American Institute of Ultrasound in Medicine. Dr. Brian Fox, the president of AIUM, Professor of Radiology and Biomedical Engineering, University of Michigan. Dr. Richard Hapman, Professor of Medicine, Chair of Ultrasound Education, Director of Ultrasound Institute, University of South Carolina School of Medicine. Dr. Mike Wagner, Director of Internal Medicine Ultrasound, University of South Carolina School of Medicine. Myself, Dr. Jean Gao, Director, Ultrasound in Research and Education, Rock Vista University. Thank you.
Okay, thanks Professor Gao to introduce, and welcome all the most prestigious experts to join us. I'd like to invite President Wen He and President Brian Fox to give us the opening speech on behalf of CUDA and AIUM. Dr. He, please.
He, I'm from Beijing Tiantan Hospital, Capital Medical University, and the president of CUDA. CUDA means Chinese Ultrasound Doctor Association. China has made great progress in prevention and control of COVID-19. In meantime, ultrasound plays an important role in prevention and control of COVID-19 too. However, this epidemic disease is spreading all over the world. In order to introduce experience of China's prevention and control measurements in ultrasound to the United States, CUDA is invited by AIUM to share the ultrasonic experience of prevention and control of COVID-19. CUDA and AIUM will cooperate to host this conference. Together with global ultrasound doctors, we will fight against the COVID-19 through academic exchanges and experience sharing. I hope this conference could provide valuable information to ultrasound doctors. At the same time, it could be beneficial to strengthen the cooperation and exchanges between China and the United States in ultrasound. Thank you very much.
Thanks, Professor He, for the opening speech. We believe this event must bring valuable experience to ultrasound doctors. Now, it's our great honor to invite President Brian Fox to give us the opening speech. Please, Dr. Brian.
Welcome to this international web conference on the use of ultrasound in the evaluation of COVID-19. I'm Brian Folks, the president of the American Institute of Ultrasound and Medicine, and it is my honor to join with Dr. He of the Chinese Ultrasound Doctors Association in hosting this event. The AIUM and CUDA last year signed a cooperative agreement, and this web conference is part of the efforts together. This is a very difficult health crisis that we face, and we appreciate the opportunity to hear from our colleagues in managing the healthcare needs of the patients affected. This web conference is our opportunity to hear from some of the physicians who were the first to have to adapt to ever-changing conditions, fighting a virus without substantial knowledge of its contagion or its effective treatment. We are fortunate to have them share their knowledge and experience with us today. The AIUM will continue to collaborate on such efforts like this to increase our knowledge and understanding and assemble information that will be available through our website for use by healthcare providers and researchers everywhere. It is our responsibility to provide the best possible information and guidance on the safe and effective use of ultrasound to the benefit of our patients during this pandemic and always. Thank you for your attention at this web conference, and my thanks to all those who helped organize it and make it possible.
Thanks, Professor Brian. We do believe that the outbreak of the virus must be controlled quickly. And today's event will include 3 sections: lectures, case sharing, and discuss. So this conference is live broadcast from 2 platforms, both in China and international. Please follow us. And during the conference, if you have any questions, please type it and send it to the message area of the platform. So now, to open up today's lecture session, the first speaker is Dr. Xiang Fei. He is going to give some advice to ultrasound doctors about how to avoid infection during the ultrasonic diagnosis and treatment procedures. Please, Dr. Fei.
Distinguished President of the General Assembly, Professor Foglers and Professor He Wen, and distinguished ultrasound doctors from both China and the United States, good morning. I'm Dr. Fei Xiang from Ultrasound Department of PRA General Hospital, the first medical center. And at present, the prevention and the control of the outbreak caused by the COVID-19 is in critical condition. The Chinese ultrasound doctors have been aware of the importance of protection since the beginning of the epidemic. The CUDA organized experts to write Chinese expert consensus on protection for ultrasound healthcare workers against COVID-19. So today, it's my great honor to introduce and analyze the prevention and control experience from China to you with the help of this meeting. And we know that COVID-19 is now a worldwide public health problem. In the early morning of the March 12th, the WHO officially declared COVID-19 a pandemic. It is highly contagious and spread rapidly with a wide scale of outbreak, making the prevention and control very difficult. And in the early stage, more than 3,000 healthcare workers have been infected in China in the early stage due to the lack of awareness of the infectivity and insufficient protective measures. But now, more than 40,000 healthcare workers across China have ridden to the rescue in support of Wuhan City in Hubei province. And so far, there is zero infection among these doctors. Therefore, effective protective measures are very important. So, I will introduce our prevention and control experience in 3 aspects: workspace, ultrasound equipment, and doctor's personnel protection. And firstly, let's look at the workspace. The workspace in ultrasound department should be divided into 2 areas. It includes 2 passages and 3 sections. 2 passages, the one passage for the access of the medical workers, and the other for the patients and his families. 3 sections are clean areas, buffer zones, and contaminated areas. This is the sketch map of 2 passages and 3 sections. The clean area is for healthcare workers to rest, eat, change clothes, and so on, where irrelevant persons are strictly forbidden to enter. Any work clothes, masks, hats, gloves, shoes covers, and so on used in the office are not allowed to be brought into the clean area. A buffer zone is mainly for preparation, including putting on or take off protective items. And here we need to focus on the buffer zones. And from this picture, we know the buffer zone is divided into 2 parts, buffer zone A and B. Buffer zone A is for putting on protective gears, where buffer zone B is for putting off the protective gears. But in the buffer zone B, and we can know that the buffer zone B is further divided into 2 parts, B1 and B2. B1 is for taking off eye protection or face shields, protective clothing, boot covers, outer gloves, and so on. The B2 is for taking off work clothes, isolation gowns, hats, inner masks, inner gloves, shoes covers, and so on. And the people, when entering into the hospitals, follow the route starting from the clean area, buffer zone A, and to the contaminated area in order. The process is reserved when exiting hospitals, contaminated area, buffer zone B, and clean area. And in triage area, the staff should be provided primary or secondary personnel protective equipment, short for PEE. Protective items include surgical masks or medical protective masks, for example, the N95 masks, eye protection or protective face shields, latex gloves, disposable work hats, work clothes, and isolation gowns, disposable shoe covers. Hand hygiene should be strictly performed during consultation. Now this is very important. Now, in the triage area, in addition to following the normal process, the staff also need to do the following work: ask for medical history symptoms, check the temperature of the patient, and report any case where the patient has fever and suspected symptoms. Ultrasound consulting room environment. There are 3 measurements are very important for the ultrasound consulting environment. The one is make the room well ventilated, at least once in the morning and once in the afternoon for no less than 30 minutes each time. And 2, Disinfect the ground and the surface of objects in the room with chlorine containing disinfectant or diluted it for disinfectant at a ratio of 1 to 50, 1 or 2 times per day or at any time once it is contaminated. And third, disinfect the air with UV lamp irradiation for 6 minutes after the end of daily diagnosis and treatment. The above 3 points are very important for the disinfection of consulting room environment. Ultrasound equipment. For the US equipment, we use 97% alcohol or 3% hydrogen peroxide. Sterilization of ultrasound probe is very important. 75% alcohol or disinfectant wipes are used for disinfection. And the supplies for patients are another thing that we should focus on. Changing these supplies at least once every half a day or intermediately once they are contaminated. Of course, it is recommended to use disposable bed sheets to prevent cross-infection where applicable for healthcare institutes. Proper disposal of medical waste can effectively reduce or prevent the spread of the novel coronavirus. Medical waste such as the disused masks and hats should be disposed of in the medical trash can. Disinfect the trash can twice a day using 75% alcohol or chlorine containing disinfectant. All waste of patients and protective equipment for health care workers should be deemed infectious medical waste and placed in a dedicated packing bag or shop container for medical waste. And we must pay much more attention to this. A note marking coronavirus disease 2019 or its abbreviated for COVID-19. And the surface of the packaging bag should be disinfected or packed with another packing bag dedicated for medical wastes. For suspected or confirmed patient, it is recommended to use exclusively machine and disinfected after receiving treatment. It's important to remember that we should provide protection to ultrasound system. And secondly, we should disinfect the ultrasound probe and the cable, host machine display, operation panel, workstation after examination. Protection for healthcare workers in ultrasound. The doctor should take the primary protective measures to carry out the ultrasound examination of the ordinary patient. These items include work clothes, disposable work hats, latex gloves, surgical masks. For the people from the outbreak area or under quarantine, and wish to take the secondary PPE, including wearing a medical protective masks, N95 mask or higher, eye protection or face shield, latex gloves, disposable work hats, or 2-piece surgical gowns, isolation gowns, and disposable shoe covers. And the same protection should be provided for participants such as medical assistants and nurses, as that for physicians who stay in the same room. This is a picture of secondary protection. And finally, and most importantly, protection against the possible aerosol transmission. The terrorist PPE, including medical protective masks, N95 masks, or higher, full-face respirator or higher level powered air purifying respirator, positive pressure headgear, latex gloves, disposable work hats, two-piece surgical gown, isolation gown, disposable shoe covers, and protective clothing and boot covers. The key to the protection that we should remember: the first is hand hygiene, and second is correct and effective protective measures and methods. These 2 points are very important for doctors to prevent infection of COVID-19 in our work. In summary, in view of the complicated outbreak currently, all our ultrasound workers must strictly conform to the requirements for protection against COVID-19, get better nutrition and rest, do a certain amount of exercise regularly, maintain good physical strength, and improve self-protection. We should work together in fight against COVID-19 to protect the health and safety of ourselves and others, and strive for a total victory in the fight against COVID-19. Now I want to say, let us go forward together with our united strength, and thank you for your attention.
Oh, sorry. Okay, just the mute. And thank you very much for the Dr. Fei, the action lectures and your suggestions. Hopefully, by taking strict protect measures, ultrasound doctors can work more safely and do more contribution on fighting virus. So let's move on to the next topic. Professor Zhou, she will share us the experience of COVID-19 and the critical cardiac conditions. Please, Dr. Zhou.
Hello, everyone. I am Dr. Qin Zhou from Wuhan. My city has overcome the hardest time and now is back. I'm glad to have this chance to share some experiences from the front line in our hospital, which was the hospital to cure the critical COVID cases. My topic is COVID-19 and the critical cardiac condition. Recently, a novel coronavirus has infected cluster in December 2019 and caused an outbreak of severe pneumonia with worldwide human-to-human transmission. COVID-19, named by WHO, has become the most serious pandemic since 1918. As of last week, there are more than 2 million confirmed cases all over the world. Currently, new confirmed cases and deaths caused by COVID-19 still increased daily. Chinese clinical guidance for COVID-19 has divided patients into 4 types as mild, moderate, severe, critical. Patients with one of the following 3 conditions are considered as typical type. First, respiratory requiring mechanical ventilation. Second, shock. Third, multiple organ failure requiring intensive care management. The critical condition developed especially in patients with severe hypoxia, electrolyte disturbance, coagulation disorder, or multiple organ failure. The disease severity was correlated with age, basic diseases, and severe pulmonary disease. Currently, there is no specific drug for COVID-19. Patients in hospital must received supportive treatment, including intensive care, albumin infusion, continuous renal replacement therapy, mechanical ventilation, or even ECMO. Here, in my presentation, we focus
on the heart. And we found that critical cardiac condition might be in correlation with COVID-19, and there are some clinical evidence supporting it. The first onset symptom of patients include certain cardiovascular symptoms, such as palpitations, chest tight, or chest pain. In addition, the ECG changes and the elevation in cardiac biomarkers like troponin I and NT-proBNP were observed in patients with COVID-19, suggesting myocardial injury and heart failure. What's more, cardiac arrest, respiratory or circulatory failure that happened during the hospitalization might also be evidence that the disease has influence on the heart. Furthermore, there are certain secondary consequences it brings, like effects on the right heart function, enhanced right atrial pressure, and pulmonary artery pressure. 4 different cases were assumed to induce critical cardiac condition. Cardiac injury induced by the virus itself. This mainly refers to patients without any pre-existing or coexisting heart disease. The second type were patients with history of heart disease prior to infection with SARS-CoV-2. Acute cardiovascular events may also occur during the hospitalization in patients with COVID-19, and multiple organ dysfunction syndrome modes may induce myocardial injury too, leading to critical cardiac condition. We start with the first type, cardiac injury induced by the virus itself. There are etiological evidence supporting that cardiac injury might be induced by the COVID-19. The novel coronavirus in 2019 has been discovered as the 7th member of enveloped RNA coronavirus and is highly similar to severe acute respiratory syndrome coronavirus SARS-CoV, which caused an outbreak in 2003. It has highly affinity with the human angiotensin II receptor, ACE2, which mediates the emission of endothelial cells. Previous studies have shown that SARS-CoV could induce myocardial inflammation and myocardial injury through ACE2. Therefore, it is presumed that the novel coronavirus may also lead to cardiac dysfunction and myocardial injury in patients with COVID-19. Let's see a case. We follow up the patient who was admitted to hospital at January 26 with fever, shortness of breath, and chest tightness. The blood pressure rose up with high heart rate when he was admitted. He used to be a strong young man, only 35 years old, and had no history of any underlying cardiovascular disease. His CT showed multifocal consolidation and ground glass opacification in both lungs, confirmed as viral pneumonia. The hemogram showed an elevation in red cells, C-reactive protein, procalcitonin, and D-dimer, with hemoglobin decreased, which also indicate inflammation. Elevation in the level of cardiac marker was observed. Levels of creatinine kinase were more than 3 times higher combined with elevation in NT-proBNP. The result of ECG suggested tachycardia, which might also be in correlation with myocardial injury. Look at the CT. Here is the so-called white lung. This white lung in ultrasound, we could see here diffused B lines and the fusion of those multiple B lines. In terms of echo, based on various view of the heart, we could know that all the chamber size, including left atrium, left ventricle, right ventricle, were with within normal range. Thinning or thickening of the ventricle wall was not observed either. There was no significant abnormality in myocardial motion and no pericardial effusion was observed. The pulmonary artery was not widened and there was no abnormal blood flow signal in color Doppler imaging. Tissue Doppler imaging showed the mitral annulus, the ratio of EA was greater than 1, and the taps, which reflect the right systolic function, were within normal range, suggesting no significant diastolic or right heart dysfunction. The velocity of pulmonary artery was 84 centimeters per second without significant regurgitation. We could also see a VV ECMO tube in his inferior vena cava. Generally, not too much findings were observed in echo. Here is the tube in the vena cava. During his hospitalization, he received comprehensive treatment, including supportive care, antibiotic therapy, antiviral therapy, CRT, mechanical ventilation, and the VV ECMO. However, due to extensive and severe lung lesion, hospital stays of this patient was lengthy. He stayed more than 2 months in hospital, during which lower extreme venous thrombosis were also developed. Here we could see the thrombus in the vein. The patient was was admitted to hospital in an extremely critical condition, even though his family still believed that he could recover, willing to save his life at any cost. His doctor never gave up either. And as a patient with COVID-19, he also received financial support from the country. After 25 days supported with ECMO, he miraculously recovered little by little. At present, all the tubes on his body was removed, and he can talk by the cell phone with his wife every day, and he saw his baby. This is the video they talk in Wuhan language. It's fighting. Okay, so let's see another case. Nevertheless, real patients still showed signs of cardiac dysfunction induced by COVID-19. This case is reported 21 years old, a female. Her troponin I level was enhanced and NT-proBNP was enhanced also. The chest radiogram revealed a multifocal consolidation on both lungs field and cardiomegaly. Chest CT show a multifocal consolidation and the ground glass opacification in both lungs in the lower lobe and the peripheral dominant distribution. From CT, the myocardium was hypertrophied due to edema combined with subendocardial perfusion defect on the lateral left ventricle. ECG showed no non-specific intraventricular conduction delay and multiple premature ventricular complex. The echo showed severe left ventricular systolic dysfunction. Cardiac MR revealed a diffused high signal intensity in the left ventricle myocardium on T2 short tau inversion recovery imaging. Let's see the echo. Echo showed a significant enlargement in left ventricle. The amplitude of the myocardial wall motion was decreased, which suggested left ventricular systolic dysfunction. Overall, the multi-modality imaging include echo, CT, and cardiac MR. Identified this was a COVID-19 related myocarditis. So, in general, for patients without any history of disease, cardiac injury might be induced by COVID-19. Typical echo signs which could be seen in fulminant or classic acute myocarditis, like ventricular enlargement, myocardium thickening, or cardiac dysfunction, were not often observed in COVID-19 patients. Although certain positive findings in echo could be detected, especially in severe and critical cases, such as pericardial effusion, signs of pulmonary hypertension, and right heart lesions. However, the signs were not specific. The second type was patient with history of underlying cardiovascular disease. The present study showed that patients with pre-existing cardiovascular disease might be more susceptible of COVID-19 induced heart injury based on the clinical data in our hospital and the Zhongnan Hospital in Wuhan, another big hospital in Wuhan, in terms of history of coronary heart disease and hypertension, as approximately 30% and 60% occurred cardiac injury respectively, which were significantly more prevalent than those without cardiac injury. Although there are few pieces of evidence to establish a direct association between cardiac injury and cardiovascular comorbidities, it is rational to presume that once patients with pre-existing heart disease were infected with severe pneumonia, myocardial ischemia, or cardiac dysfunction were more likely to occur, ultimately leading to a sudden deterioration. Large-scale clinical studies had indicated that comorbidities, including hypertension, diabetes, were present more often among patients with cardiac injury, leading to adverse clinical outcome. The third part is acute cardiovascular events, such as acute myocardial infarction may also occur during hospitalization, which might be correlated with severe hypoxia or systemic inflammatory response. The virus might trigger inflammation and the release of C-reactive protein, interleukin-6, and vascular endothelial growth factor, VEGF. Virus also induce increased platelet and neutrophil activation by affecting inflammatory cytokine secretion, endothelial function, coagulation, and fibrinolysis. Virus-induced response have potential adverse effects on cardiovascular morbidity and may trigger acute cardiovascular events. Let's see a case. A 61-year-old woman was admitted to hospital with fever, shortness of breath, and chest pain. The respiratory rate was 30 times per minute with decreased saturation of blood oxygen. She had a history of coronary artery mild stenosis. Exact details about her heart disease and drug usage was not available. CT confirmed as a viral pneumonia with characteristic changes of COVID-19. Similarly, The hemogram showed an elevation in red cell, C-reactive protein, D-dimer, and other. This is her first bedside echo. The diameter of left atrium and left ventricle were within normal range, while the right ventricle seemed expanded. Thinning or thickening of the ventricle wall were not present. However, the right ventricle free wall motion was decreased, and also the left ventricular posterior wall as well. Meanwhile, pericardial effusion was observed. The peristernal short axis view at papillary muscle level also demonstrated the enlargement of right ventricle chamber and abnormally motioned posterior wall. Here we could see mild tricuspid regurgitation, and the peak velocity of it was 2.4 meters per second. So the pressure is not too high. The second echo was performed 2 days after. The result was basically consistent with the first echo, but even worse. The left side heart chamber size looked not changed too much compared with the before. However, the heart rate was faster, which was not good. The right heart enlarged obviously, and the peak velocity of tricuspid regurgitation increased than the first echo. The velocity was 4.5 meters per second, suggesting enhanced pulmonary pressure. Echo also identified the dysfunction of both left ventricle and the right ventricle by providing the LVEF was about 42% to 45%, and the TAPS was of 1.3 centimeter. Based on what we observed on series echo, it was suggested that the patient had acute myocardial infarction. Consistent with the echo, the level of cardiac marker, including creatinine kinase MB, troponin I, and NT-proBNP, were also elevated. At the day the second echo was done, the level of these three markers increased significantly and fall down gradually. 6 days after, the patient eventually died. From the whole clinical causes of this case, we could see when she was admitted to hospital, degree of blood oxygen saturation was only 63%, suggesting critical condition of severe lung lesions. Echo exam found regional wall motion abnormality and both sides of the heart dysfunction, which indicates possible myocardial infarction, and elevation in cardiac marker confirmed this. At the 26th day of her hospitalization, she was gone. The suspected causes for the death may be involved within the 18 days of systemic inflammatory response, cytokine storm, and the severe hypoxia, which might be the inducement for acute cardiovascular events. Then it in turn aggravated inflammation. This formed a vicious circle leading to the death. As there are not too much findings in echo in most patients with COVID-19, especially those without history of heart disease, American Society of Echocardiography published a statement on protecting of patients and echocardiographer service providers during the 2019 novel coronavirus outbreak. It highlighted the need to avoid performing rarely appropriate exams. It is important to determine the clinical benefit of echo for symptomatic patients whose SARS-CoV-2 status is unknown. Knowing the status of a patient allows for the appropriate application of personnel, protective equipment, and its conservation when not needed, in addition to reducing the exposure risk of ECHO personnel. Recent research suggested that POCUS was helpful mostly in the following condition. Firstly, heart failure, based upon the findings of symptoms and elevation BNP value. POCUS was helpful in suggesting the need of heart failure therapies. Second, in acute pulmonary embolism, ECHO can be used to differentiate between a right versus left side heart lesion, leading to hemodynamic deterioration and the symptoms observed. With symptom and elevated cardiac marker level, ECHO was also useful in supporting evidence of acute myocardial injury. So let's see under what conditions ECHO is necessarily needed. The left case was a patient with heart failure. The bedside cardiac ultrasound revealed a severely enlarged and globally left ventricle with severe global impairment of systolic function. The middle case was a patient with acute pulmonary embolism. The limited transthoracic echo showed that the right ventricle was severely enlarged with impairment of function. The right atrium was mildly enlarged. There was moderate tricuspid regurgitation. Severe pulmonary hypertension was present, and the pulmonary artery systolic pressure was estimated as 74 mmHg. The right case was a patient with acute myocardial injury. There were extensive wall motion abnormalities involving the basal to apical anterior wall. Here, it was an apical aneurysm with mural thrombus. In above conditions, ECHO was helpful and needed in diagnosis and suggesting for necessary treatment. The last part is that the critical cardiac condition might also be induced by multiple organs dysfunction. Multiple organ dysfunction is defined as the concurrent dysfunction of two or more systems, which be seen in patients with virus acute critical disease. Although traditionally regarded as disease confirmed to lungs, acute pneumonia has important effects on virus organ. Let's see a COVID MOS case. This patient was a female, 56 years old. The blood pressure was lower than normal and the blood oxygen saturation was only 78% when she was admitted. She had a history of renal insufficiency, no other disorder. Her CT is a typical COVID and very bad. During her hospitalization, she had a multi-organ dysfunction, including the kidney, heart, liver, lung, and brain dysfunction. Here is a timeline for this patient. In the beginning, her condition remained stable after admission. However, from February 19th to February 22th, the patient's condition worsened suddenly. She had coma and dilation and of pupil once and needed invasive ventilation due to decreased of blood oxygen concentration. At the same time, ECHO suggested left ventricular systolic function with signs of pulmonary hypertension. A few days afterwards, with the improvement of her general condition, cardiac function returned to normal again. This suggested that critical cardiac condition might also be induced by severe general condition and multiple organ dysfunction. The patient underwent 4 echoes during her stay in hospital. The initial one did not have too much findings. However, it was worth noting that a short term of cardiac dysfunction occurred accompanied with her condition deteriorated rapidly and her consciousness was lost. The series echo showed that her left ventricular ejection fraction went down from 55 to 48%. Tricuspid regurgitation and right atrial enlargement were also observed for a short time. Fortunately, her last echo back to normal because the active and effective clinical treatment. Her CT recovered gradually and other organ function improved as well. Now she is out of hospital. This is a happy ending. Why is there transient heart failure in the condition of multiple organ failure caused by viral pneumonia? There are several mechanisms: circulating inflammatory mediators or direct infection of cardiomyocyte with pneumonia-causing organisms, or both these two mechanisms can lead to non-ischemic myocardial injury. Transient disturbance of endothelial function and vascular tone driven by the systemic response to infection can increase left ventricle afterload by increasing the peripheral microvascular resistance. So let's do summary. Although certain positive findings in echo were discovered, like pericardial effusion, sign of pulmonary hypertension, typical echo signs were not observed in COVID-19. Pre-existing cardiovascular disease might be more susceptible to COVID-19-induced heart failure, leading to adverse clinical outcome. Virus-induced response animals may trigger critical cardiac condition, and echo is very helpful in evaluating the process. Thanks for listening. So let's fight against the virus together. Thank you.
Thanks, Dr. Zhou, for your insights. It's a good lecture and give more details about the system situation on the severe cases. Next speaker is the Dr. Yuan. Today, she is going to talk about pediatric ultrasonography in COVID-19 epidemic. The experience from the Wuhan Children's Hospital. Please, Dr. Yuan.
Good evening, everyone. I'm so honored to give this presentation. My topic is about pediatric ultrasound in COVID-19 pandemic experience from Wuhan Children's Hospital. The first part is about the COVID-19 in children current status. Our hospital is the only designated children's hospital in Wuhan for treating COVID-19. We set up 11 isolation wards. Our experience has shared in the Chinese statements for the COVID-19 disease. But for the diagnosis for children, the criteria is the same as adults. We should combine the epidemiological, clinical, and etiological characteristics. But due to the different symptoms of children, we give another classifications, especially in pediatric severe and critical cases. Now let's give the picture about the COVID in children. Firstly, we should say these papers published in late February. It's about the epidemiology. Children were mainly affected from family custom outbreak, and the incubation period is longer than those in adults. Influenza viral screening is necessary to rule out the possible co-infection, considering the seasonal overlap. The next is about the screening research. 745 pediatric close contacts were screened by the infection, and 10 children tested positive. The mobility of the children is much less than those in adults, and some children remains positive results in rectal swabs weeks after nasopharyngeal swabs turned negative, suggesting potential persistent fecal viral shedding and fecal oral transmission. Another paper is from my college. It's about neonates. 33 neonates born to mother with COVID-19, including 3 neonates identified. The sources of COVID-19 in the neonates' upper respiratory tracts were likely maternal in orange. The vertical maternal fecal transmission cannot be ruled out. And the largest single center research is from another college published on New England Journal. 171 children were confirmed COVID-19 by swabs test among 1,391 tested children, including 12 asymptomatic cases. All the asymptomatic cases showed CT scan abnormality. Most infected children appears to have a milder clinical course. Asymptomatic infections were not uncommon. The largest pediatric research is from the Chinese CDC data. Over 200 COVID-19 children, including 34% confirmed and nearly 66% suspected cases. Children at all ages and appears susceptible without gender difference and more vulnerable in infants, and the severe and the critical cases accounts for nearly 6%, is much less than in the adults. Because as we know, CT is a vital important tool for the disease diagnosis, and the features has his typical characteristics. And this is from my college's paper. CT features can be divided into 4 stages, but there's something different between children and the adults. The early stage, we can see the bilateral and the unilateral pulmonary lesions. Typically, we can see subpleural lesions, mainly in the lower lobe, GGO, and the consolidation. Most of the children only stayed in this early stage, and less children can move to the advanced stage. We can see the scope of the lesion expanded and the density increased. And the rare children can go to the critical stage. If 2 lobes involved, we can see the white line. And the last stage is the recovery stage. And let's get the summary. Children were mainly infected from family cluster outbreak. Compared with the adults' COVID-19 cases, children's clinical and CT presentations are mild, with severe and critical cases much fewer. Most had better prognosis, and in mild cases, they recovered 1 to 2 weeks after disease onset. The next part is about the ultrasound diagnosis and case report. As we know, ultrasound has the advantages of non-invasive free radiation and bedside. In our clinical settings, we used the common and handheld portable ultrasound machines. And this COVID-19 disease can attack multiple organs, especially lung and heart. So we use ultrasound to get multiple organ detection. And before the exam, we lead preparations such as PPE, and sometimes we give marks to patients and parents with coughing and sneezing, and sometimes we lead sedation for children, and disinfection should be pay more attention before and after the examination. As for the protocols, I think the ultrasound is the same as the ASE, is similar with the recommendation from ASE statement on echo service during the virus outbreak. But focus is necessary to obtain diagnostic views and get comprehensive enough imagings to avoid back to the words, tailoring study to the indication and play in advance. Course lung is the target organ in the COVID-19, so lung ultrasound played a vital role in this disease diagnosis and monitoring. Lung ultrasound cannot create direct images of the pulmonary parenchyma, but can be used for the diagnosis and monitor of lung diseases by utilizing artifacts formed by different pathological changes. We can see this illustration. This is the normal lung images. Images can be changed if the air fluid ratio changed, which reflects the different pathological changes in different lung diseases. And the exam preparations included probe selection. In pediatric population, we normally use the high-frequency linear array probe 5 to 10 megahertz and the convex probe. And the present, we normally use the small path, and the beginning focus always in the level of pleural line, and harmonic can get the optimize of the imaging. As the protocol, the children should have the position of supine or prone or set position. Cause the lung disease can be located in different regions of the lung, so we normally divide the two lungs into 12 regions according to the anterior and posterior axillary line and the line between the lippos. The scanning method, we normally use perpendicular scanning. Put the probe perpendicular to the ribs of the children is the most important scanning method to obtain the reliable imaging for diagnosis. Sometimes we also use the parallel scanning. Now, let me introduce some terminal about the lung ultrasound. In normal person, we can see the pleural line and the line sliding and A9. This is a picture. Pleural line is a smooth, regular, and relatively straight hypoiconic line, and it reflects the pleural non-surface interface. And the A9, just like this line, situated below the pleural line and present as a series of smooth, clean, regular, and equidistant hypoiconic parallel lines. And in these two videos, we can see this the skin, this is the ribs shadow, and this is the pleural line and the A9. This is the same. But in the COVID-19, we can see some typical signs such as B9. B9, just like this one, it's a discrete nazi-like vertical hypoiconic reflection artifacts that arise from the pleural line, extend to the bottom of the screen without fading and move synchronously with sliding. It is caused by an ultrasound wave encountering the alveolar gas-liquid interface. So normally in normal patients, we can't see the benign, but in patients in 4 to 7 days neonates, we can see some few benign due to the premature nuance. And if we see benign, it means the L fluid ratio decreased. Sometimes it's their pulmonary edema. And this video shows this benign. Firstly, this confluent benign entire intercostal space filled with benign between two acoustic shadows of the ribs. In more serious case, we can see the compact benign. The concentrated benigns can cause the shadow of the ribs disappeared. And as we know, the lung disease can be different in different regions of the lungs. So we need to check the regions one by one. For example, in these 4-day neonatal scanning from the anterior chest wall, we can see visible A9, and this is A9, and few B9s, it means normal. And when we scanned from the back chest wall, this period of A9 and confluent B9, there is some pneumonia in this field. And this is a paper regarding the correlation between GGO in CT scan and B9 in ultrasound. In diffused parenchymal lung disease, GGO as present in acute pulmonary edema has been associated with presence of B9. And another typical signs in COVID-19 is consolidation. It means the tissue-like density may be accompanied by L brachygram, fluid brachygram in the most severe cases. And in this video, we can see the lung consolidation. And this is the L brachygram with tail, and fluid brachygram, slightly fluid brachygram, and pleural effusion. And this video, we can also see the lung consolidation and the fluid brachygram and the pleural effusion. As we mentioned in previous CT features, the typical imaging features is the subpleural lesions, especially in the early stage. So we can also see it in the ultrasound. This is the subpleural consolidation here, and the interaction of continuity of the pleural line, this pair of A9 and the confluent B9. Lung ultrasound in children has its own specific advantages. Because children have small size of the chest, so it's optimal for visualization. All lung ultrasound signs in adults are alike in children in both normal and pathological conditions, and is non-ionizing, so it's more suitable for chronic and ICU cases. So to reduce the cumulative radiation dose, the indication from TTN to RDS, from bronchiolitis to post-op lung complications, especially for pneumonia. What about the lung ultrasound in pediatric COVID-19? we can see specific signs. For example, A lines disappear and the approval line is abnormal. B lines are visible in the non-consolidated eye. The main manifestation of mild or early pneumonia may be presented as small subpulmonal focal consolidation. Lung consolidation accompanied by air bronchogram or fluid bronchogram. Lesions may be located at one or two positions in the lung fields. As for the comparison of ultrasound and the X-rays, if we put X-rays as the reference standard, non-ultrasound diagnosis accuracy seems good, especially in consolidation subgroup. The specificities up to increased to 97%, and the sensitivities is 86%, PLA 28, and NLA 0.1. And in this study, we can see ultrasound can get nearly 40% reduction in X-ray use in pediatric population. Now, let me introduce the critical cases in our hospital. It's male, 13 months old. The admission complaints including the digestive and respiratory and urinary system. They were diarrhea, vomiting, fever, and shortness of breath and oliguria. And the medical exam showed high temperature, increased heart rate, respiratory rate, and blood pressure. And the percutaneous oxygen saturation obviously decreased to 80%. So the patient had admitted to ICU wards. In the first day, the X-rays and chest CT showed obvious abnormal in lungs, enhanced bilateral bronchovascular shadows, consolidation, and GGO in the right lung. Because it's winter and we are COVID-19 outbreaks in China. There are COVID-19 outbreak in Wuhan. So we give the influenza virus screening. The test is negative. And FOBT, weak position, still HRV, antigen test positive. There were no familiar COVID-19 patients, and the parents' CT was normal. The patient has obviously increased CR, BUN, and UA. It indicated acute renal failure. And also see the obviously increased BNP and the CKMB increased. And so it indicated the myocardial damage. As for the biomarker of infectious disease and cellular immunization, during the different days in the hospitalization, we can see the lymphocyte decreased and the CRP increased in the previous days and recovered in the following days during the hospitalization. Cause, there are the obviously abnormality in BNT and the CKMB, indicating the cardiac damage. So we do the echo as the first day, we can see there are mitral regurgitation and tricuspid regurgitation. The pressure of the tricuspid regurgitation was 20 millimeter of mercury. It seems the normal pulmonary artery pressure. As for the functional assessment, we can see the global systolic function of left ventricle was normal. EF was 69%. But when we get the TDI imaging of the basal septum, we can see the velocity, as velocity decreased to 7. It suggested the decreased longitudinal systolic function. And the E-peak and A-peak looked similar. The velocity was similar. It suggested, at his age, it suggested decreased diagnostic diastolic function. The day 2, the baby's situation deteriorated, persistent fever, and we set up the invasive ventilation, and the swabs test negative. And then we used ultrasound in the SU for the disease monitoring. The lung ultrasound showed the right lung. There are pulmonal infusion and diffuse benigns in the upper right lobe. And it's more severe in the lower right lobe. We can see the lung consolidation and the L bronchograms. As for the left lung, it's much better. The arterial pleural effusion and a few benigns. And the echo imaging in day 3, we can see the movement of the whole heart decreased, and the left ventricle size decreased, left ventricle wall thickness increased, and the tricuspid valve here is more worse. There are moderate to severe tricuspid regurgitation, and the pressure slightly evaluated to 30. It means it suggested decreased right ventricle systolic function, and the slightly evaluated pulmonary artery pressure. As for the functional assessment, we can see the global left ventricle systolic function decreased to ejection fraction 55%, and the S velocity of TDI images has decreased to 6 to 7, and the E-peak and A-peak, both in the TDI and mitral inflow septums, it reversed. So it means the patient's systolic function and the diastolic function both decreased. In this day 4, the patient's symptom looks better. We can see in the right lung, the pleural effusion absorbed, and the lung solidation getting better, diffused benign, and the lung siding size can be seen. And the left lung, same as previous. And this is the kindling imaging, swelling of the both kidneys and mild hydronephrosis. And the echo, we can see the mild to moderate TI is better than previous days, and the movement of the heart seems better. The pressure of the tricuspid regurgitation was 22, it's decreased. And the left ventricle systolic function recovered, EF 62%. As for the diastolic function, we can see the S velocity increased above them, about to 13, and the E-peak and A-peak, the ratio recovered to normal. So the systolic and diastolic function recovered. In the day 8, finally, we find the virus evidence is positive now. So we get the etiological evidence combining with the imaging presentation and coupling with shock RDS and ARF myocardial damage, we classified this case as a critical case. We used comprehensive treatments, including invasive ventilation for 10 days. In the day 11, when we routine monitor the patients, we find there were subpleural consolidation in the left lower lobe. This is the room imaging, and the discontinuous of pleural line and mild pleural effusion. And this video, we can see the subpleural consolidation in the left lower lobe, and there is the L brachiogram pleural effusion. So it means there is the progress in the left lung. The chest CT confirmed our diagnosis. Lesions obviously absorbed in the right lung and progressed in the left lung. The urinary ultrasound advised there is a normal kindling. After 17 days active treatment, the patient discharged. And the lung ultrasound shows the bilateral view benign, A9 recurrence, and invisible lung consolidation, continuous pleural line. And when the outpatient follow-up, the ultrasounds also showed normal kindlings, no hyponephrosis, and no ascites. This patient was the first critical cases in China, and the discharge diagnosis was COVID-19 and the models, and the digestive and the urinary and the respiratory and cardiac systems all involved. Take-home message. Children were mainly infected from family cluster outbreaks. Compared with adults, children's clinical and CT presentations are mild and most had better prognosis. However, some of them could be atypical or asymptomatic and a source of infection. Ultrasound is a non-invasive, convenient method for the assessment of multiple organs in children. Lung ultrasound provides valuable information for diagnosis and monitoring of COVID-19 patients. Many thanks for your attention.
Okay. Thank you, Dr. Yuan, to share with us the ultrasound features of the infected children. And thanks all of you. The lecture session is over, and there are more than 10,000 audience online from the China and the United States, even across the globe. So welcome everybody. And you can leave the message in the comment area of the platform, and we will give the answer during the discussion session on the COVID-19 section of the AIUM website. So next part is case sharing. So please welcome the co-moderator, Dr. Fei. Dr. Fei, please.
Thank you, Professor Wei Zhang, and thank you very much for your wonderful host in the opening and the lecture section. Please, you can have a rest, and we will meet you in the discussion section, and see you later. And hello, everyone. Good morning. And I am Fei Xiang, coming from the First Medical Center of PRA General Hospital. And welcome you to participate in the case sharing section thrombosis, the range and stability of thrombus, sign of secondary pulmonary embolism in early stage. So today, we invite Professor Yali Qu from Jinyintan Hospital in Wuhan City, Hubei Province, to share the case application of ultrasound in severe COVID-19 patients. Let's welcome.
I'm Qi Yali from Wuhan Jinyintan Hospital. It's my great honor to present application of ultrasound in severe COVID-19 patients. US can be used in many situations, including the examinations of lung, heart, kidney, liver, gallbladder, pancreas, spleen, blood vessels, the evaluation of blood volume, ECMO, and the guidance and the evaluation of interventional operations. Pulmonary ultrasound has great clinical value in the diagnosis and treatment of pulmonary lesions and complications in severe and critical patients. It can find benign, supplier consolidation, player synching, player effusion at the early stage of the COVID-19. As the disease progresses, it can detect hepatoid change, bronchiectasis, pneumothorax, and subcutaneous emphysema, mediastinal emphysema, and more hydrothorax. Because ICU patients were very ill and couldn't go out of the ward to do CT, they only have the results of bedside chest X-ray. This is the same patient's pulmonary ultrasound. This video shows supplier consolidation. This video shows hepatoid change. This is lung point. This is subcutaneous emphysema. Let me introduce the first case. A 45-year-old woman who had VV ECMO for 6 days. Her blood pressure fluctuated greatly, and her oxygen saturation dropped to about 80%. Echocardiography showed that the inferior vein cava catheter was too deep and reached the atrial septum at the end. It's considered that no oxygen saturation is caused by ECMO recycling. Under ultrasonic monitoring, the vein puncture tube was pulled out to 44 centimeters, and the patient's oxygen saturation increased to 92%. Her pulmonary ultrasound showed new fluid pneumothorax of the right lung, and bedside chest X-ray confirmed that. Then the right chest closed drainage was performed. Immediately, the patient's oxygen saturation increased to 98%, and the blood pressure returned to normal. The second case was a 66-year-old lady. She had fever with cough and asthma for more than 40 days. Her D-dimer was 6.91. Heart US showed a 3 centimeter by 2 centimeter lesion in the oval fossa of the atrial septum of the left atrium, with no practical and mass activity. This patient has no previous history of myxoma, and our experience shows that COVID-19 can damage the vascular intima and cause thrombosis in many patients. Therefore, in this case, we consider the possibility of thrombosis. Nevertheless, we did a contrast-enhanced ultrasound. CEUS showed lung enhancement, which supported our point of view. US examinations of inferior vein cava and iliac vein showed unstable thrombus. What's more, her left lower extremity showed thrombosis too. The third case was a 62-year-old gentleman. His D-dimer was 61.86, which was very high. His bilateral deep neck veins showed thrombosis on US. Curiously, we found some bubbles in his right posterior tibial vein. We kept our probe stable in the same section for over 20 minutes. During the time, the gas moved back and forth with a change of abdominal pressure, but it did not return to the heart or be absorbed. His right lower extremity vein was not punctured. He had no obvious damage and infectious lesions in the soft tissues of the same neck, and the gas disappeared the next day. His bacterial culture showed no gas-producing bacteria. So we have a question here. Where did the gas come from? We hope the experts can help us to analyze the reason. Thanks for your listening.
No, I mean, it's interesting that there's no.
No?
Thank you, Dr. Yaliqi and Mingbo Zhang, for sharing two interesting cases. And we know the ultrasound has a very important value in diagnosis and monitoring the changes of patient in severe. Interestingly, the Dr. Yaliqi has a question at the end of her case for all of us. So if you have any suggestion or comments, then please leave your opinion at the message area through the live broadcasting platform. And thanks again for sharing the wonderful cases. So through this case, we can see again the advantages of ultrasound image technique and the good prospects for the future development. Of course, we know there are still technical deficiencies. However, we believe that with the development of technique, the existing shortcomings will be resolved. The future of ultrasound is worth looking forward to. So the case sharing section is over. Let's move on to the next part. Thank you. I will invite my companions to host the discussion section. Let's welcome the Professor Jing Gao and Professor Wei Zhang. You please welcome you.
Thank you.
Okay, thank you very much. And we already received a lot of questions about each topic. So the first question is about the Dr. Zhou Qing's presentation. And the first question about, are you instituting a specific thromboembolic risk precaution or ultrasound assessment in those patients diagnosed with the COVID-19? And another question is about case 1. So in your case 1, the CT imaging appearance to show the pneumothorax. And this is not discussed in the ultrasound find cases. So is it anything wrong in the CT or something else? So Dr. Zhou, please give some answers. Dr. Zhou, please.
Can you hear me?
Okay, here.
Thank you for the question.
I can.
I heard I got 2 questions. The first one is about the thromboembolic events. So to prevent this event, we need to tell the patient first, if the patient can be out of the bed, ask him do it every day, move his body and the legs and drink more water. But if the patient was very weak, cannot leave the bed, must stay in bed. So we doctors help the patients move the legs on bed and do the ankle pump movement. That will be very effective. And I think the therapy should be used to prevent the thrombus. But especially for those patients who was very critical, I think the dosage should be considered be larger than prevention dosage. About in terms of, but we need to be very cautious to balance the risk of the thrombosis and the bleeding. This is very important issue. In terms of ultrasound assessment, if you consider, I mean, the overall score of a patient have a high risk of thrombus, so the ultrasound is needed to screening the people. And once you find that there is a thrombus in the liver venous, so the ultrasound should be followed up every day to for the management of the patient. So this is the first question. The second one is about the case one. Case one, the CT was not wrong. There, the patient was very critical. He did have pneumothorax. Since he is very severe, so once we found the pneumothorax, so the gas was drained out of his lung. So the ultrasound was not performed at exactly the same time as CT did. So that is why ultrasound we did not find any gas in the lung.
Okay. Thank you for your answer and more details about the questions. Thank you. Thanks a lot. And the next question, please, Fei.
Okay. Thank you. So let's look at the second question that we collected from the website. Do you ultrasound the inferior vena cava to assess and manage volume status in the critically ill patients with COVID-19? If so, has it been helpful? So this question, I would like to invite Professor Ya Liqi to give us some opinion about it. So Dr. Ya Liqi, now you please, can you hear me?
Yes.
Okay, you please, thank you.
Yes, we do it every day. We think it helps a lot. When the diameter of inferior vena cava is less than 1.5 centimeter and the collapse index is greater than 50%, the patient needs fluid infusion. In normal cardiac function patients, the widened inferior vena cava or decreased variability indicates the excessive blood volume. Of course, there are many influence factors of this method, including the ventilator parameters, the increase of abdomen pressure, cardiac insufficiency, venous thrombosis, the influence of ECMO pipeline, etc. However, if the patient is monitored every day, the changes of inferior vena cava can reflect the changes of blood volume more accurately when other conditions are reflectively fixed. Thank you.
Okay, thank you for your answer to this question. So as far as this question, I'd like to invite Dr. Mingbo Zhang. Do you have any additional comments to this question? Can you hear me, Dr. Mingbo Zhang?
Yes, I can. I have no more addition. Thank you.
Okay, thank you. Let's move on to the third question. Professor Jing Gao, you please.
Hello, everyone. Okay, third question is about handheld ultrasound devices. Dr. Meng Wu talked about devices. So the question is, what will be the role of handheld ultrasound devices in the future in such pandemic situations with large numbers of patients presenting with infection diseases? Dr. Wu, would you like to share your thought with us, please? Dr. Wu? Is Dr. Wu there? Dr. Wu?
Yes. Thank you. Yes. Thank you for question. As an answer from three parts. Handheld ultrasound equipment will play a very important role in the future. It is small and easy to carry. It can be used in different environments, including bedside, emergency, and operation rooms. Second, it has high exam efficiency, which can reduce the contact time between doctors and patients and reduce the infection opportunity. It also enables clinicians to make correct judgment and treatment in time. So it cost is low, which allowed hospital to equip multiple sets. It can also be used by clinicians. So it is convenient to observe the change of the patient condition in time and intent and repeatedly. However, it also has some disadvantage. Its imaging quality is not so good. The operation of the clinician is often not very standard, which need to improve in the future. Thank you.
Thank you, Dr. Wu, for the answer to this question. Indeed, the quality of imaging from handheld devices sometimes not good as the stationary ones. And in addition to that, standard design probably need improved. And in addition to that, physicians who is going to use a handheld device need to be trained to improve the patient care. Thank you very much, Dr. Wu, for answering the question. Let's go to next one. Question number 4.
Okay, thank you. And the 4 questions, the first questions is about the artificial intelligence. And some audience ask about what role do you feel artificial intelligence will play in the ultrasound in the future? And I'd like invite Professor Luo to answer this question because she has a lot of research on the artificial intelligence. So, Dr. Luo, please. Dr. Luo, can you hear me?
Hi.
Okay, fine.
Oh,
okay.
I'm here. Thank you.
Yeah. Okay, thank you.
Dr. Zhang. I will answer this question now. I'm Yuko from ultrasound department of the First Medical Center of PLA General Hospital. As we were know, in the past few years, with the development of computer technology, AI had made a great stride in the field of ultrasound. In terms of diagnosis, AI can assist us to differentiate whatever a thyroid lesion or a breast lesion is benign or malignant. This is also one of the issues we are doing now. However, when it comes to future, apart from more accurate, rapid, and economic, I think the most promising future is AI may help anyone who are not in a specialty, such as surgeons, emergency physicians, or even patients themselves. To master and applied in their daily life. These are all my answers. Thank you.
Okay, thank you, Dr. Luo. Definitely, the AI is the hot topic and will play an increasing role in the medical field in the future. So thanks again. And the first question, let's move on. Please, Fei, Dr. Fei.
Okay, I'm here. Thank you. Okay, let's look at the question number 5. In this case of a very sick child with COVID-19, it seems there are extensive and frequent imaging performed throughout the hospital course. How did the ultrasound findings especially impact the management? So about that question, we would like to invite the Dr. Li Yuan to give us some answers. The Dr. Li Yuan, can you hear me?
Yeah, I'm here.
Please.
I'm
okay.
here.
Thank you.
Using echo, we detected the cardiac systolic and diastolic function impairment and pulmonary artery pressure increase. The echo monitored the disease progress and guidance the usage of cardiovascular drugs. Using lung ultrasound, we detected A9, B9, and pleural 9 consolidation and pleural effusion, which reflect the pathological change. For example, pulmonary edema and consolidation. Especially during the monitoring, we found the subpleural consolidation in the left lung, which indicated the progresses in the left lung and confirmed by CT scan. I think the lung ultrasound is convenient and free radiation, suitable for disease monitoring and treatment guidance. Thank you.
Okay, thank you, Dr. Li Yuan, to give us his opinion about this question. So we know the ultrasound is very convenient. So I think it is very useful to monitor the changes of the patient, especially for children. Thank you. So let's move on to the next question. The Professor Jing Gaoyu, please.
Okay, next question is about the protocol of the scanning, performing ultrasound scan. So this question is, do all patients wear masks while being scanned, or just those people with symptoms like a fever, cough, or patients with a suspicious of disease under observation and confirm the positive with COVID-19? This question, I would like to invite Dr. Xiang Fei to answer this question. And Dr. Fei, please.
Okay, thank you. Thank you for the good question. So we know that the patient who has COVID-19 does not always have cough, fever, or other symptoms. So with the increasing understanding of the novel coronavirus, and more evidence show that a lot of people infected with COVID-19 without any symptoms. In other words, they are asymptomatic infected. So even if they are asymptomatic, I suggest that all patients should wear masks while being scanned. That is my opinion. Thank you. Thank you.
Thank you. I agree with you 100%. Thank you. Let's go on to next question.
Okay. The next questions should ask give us the question about. Can you tell us more about how physicians and staff are being trained in the ultrasound safety protocols for COVID-19? And have you developed training videos? And are there hands-on workshops? So I think these questions may be more mentioned about the Dr. Wu. So Dr. Wu, could you give us the question about this? Give us this answer about these questions.
Thank you for your question. Can you hear me? Yeah.
Yes.
Okay.
I can.
Thank you for the question. In my hospital, the ultrasound doctors and the staff who enter the isolation ward, we have received safety training in advance by professional. By entering the COVID-19 patient's ward, then we will be carefully checked to avoid the infection. Our department made a smaller videos of the conventional protection to let everyone to know. We also arranged some demonstration a workshop to let everyone to participate in, so that they can be more familiar with the safety procedures. Thank you.
Okay, thank you very much for your answer to these questions. And we go ahead So the next question, Professor Gao, please.
Okay, question. This question is another one question. I think we can separate it into 3 questions. Okay, question is about lung ultrasound in children. Okay, question like this. Previous studies of lung ultrasound in children have showed important differences from lung ultrasound in the adults with pulmonary infections. And question 1, in your experience, I think Dr. Yuan Li probably has more experience, and she can answer this question. So question number 1, in your experience, how are the lung ultrasound findings of COVID-19 pneumonia similar to that has been reported in adults with COVID-19? And the second one, are there any important differences? First one, similarities. The second one, differences. The third one, do clinical pediatricians in China taking care of the pediatric patients understand and or perform lung ultrasound, or do they only review the report and from the radiologist or ultrasound physicians? That's 3 questions: similarity, differences, who is going to perform lung ultrasound in the unit? Thank you. Dr. Yuan, please.
Yeah,
we'd like to share your experience. Thank you.
Thank you. In my opinion, lung ultrasound mainly showed A9 disappear, abnormal pleural and B9 increase, and the subpleural focal consolidation, and the consolidation accompanied by air broccoli and or fluid brocogram, pleural effusion in COVID-19, and especially the lesion located in different lung regions in this kind of coronary writing. There were not lung ultrasound signs obviously different between children and adults, but in normal neonates, within 1 week, we can find a few B9s due to premature lung, and will disappear with lung development. In our hospital, the doctors, the physicians don't understand and utilize lung ultrasound and only review the report. But some ICU, neonate doctors, and in other hospitals learned to practice lung ultrasound and find it useful. That's all. Thank you.
Oh, thank you for sharing your experience. May I ask the clinical physicians, like a pediatrician, do they need to go through special training, how to perform ultrasound in ICU for their patients? Even they don't give a report, but they just perform ultrasound for very sick patients in ICU. Do they have special training?
Yeah, before, if the doctors would like to practice lung ultrasound in neonate department or ICU, they need to get the training and go past the examination.
Okay, thank you. Thank you for answering those questions. Let's go to next one.
Okay, and the next question is about as we learn more about the widespread inflammatory response to the COVID-19, and what role do you feel ultrasound can play in the multi-organ assessment and management? So this question, I'd like to invite Professor Mingbo Zhang. Mingbo Zhang, can you hear me?
Yes, I can.
Yes, could you give us some answers about this question?
Thank you, Dr. Zhang. I think this question I would like to invite Dr. Yali Qu to answer this question because she has been working in Wuhan for all the time. So, Dr. Yali Qu, can you please answer this question?
Yes. Yes, I can hear. It plays an important role, except for lungs and the heart. We have mentioned before, for the liver, the increase of hepatic artery velocity, gallbladder swelling, and cholestasis can be detected in drug-induced and inflammation liver-induced patients by US. In patients with increased amylase, the enlarged pancreas or exudation around the pancreas may be detected by US. The spleen may shrink, have irregular margin. In patients with acute renal insufficiency, we can see the enlarged kidney and the enhanced renal echo. It's a sign of poor prognosis that the renal artery resistance changes from high speed and high resistance to low speed and high resistance. Thank you.
Okay, thank you, Professor Yang Liqu, and give us the details. So I think this topic is the common issues about all the healthcare workers. And we want to know if the ultrasound can play the important role during the diagnosis or treatment procedures. So thank you a lot for the details. And we go ahead the next questions. So please, Dr. Gao.
Next question is rising about from the Dr. Qingzhou's presentation, case number 2 in the presentation. And this seemed to have typical features of acute viral cardiomyopathy, like wall thickening, edema, and the left ventricle dysfunction, but also somewhat atypical features such as dilated left ventricle. Dr. Zhou, in your experience, this type of ultrasound image was or was not common in patients with COVID-19 cardiomyopathy. Another question about the case 2, are cardiac ultrasound performed in critically ill COVID-19 patients regularly, or only if a patient had deterioration or some onset indication for cardiac ultrasound? Questions. Dr. Qingzhou, like to share your experience.
Okay.
Would you please? Okay.
About case 2 in presentation, that case is very rare. Actually, we did not meet this kind of case in Wuhan here. The case I present is a Korea case published on the Journal of European Heart Journal. So if anybody are interested in that one, could review it. Another question is about, did echo performed routinely? Actually not. Here in Wuhan, at least in Wuhan not. Doctors only apply echo exam when it was needed. Like patient had a deterioration or some new cardiac related signs occurred, like symptoms of heart failure, elevation of cardiac enzyme, or tachycardia. I think about this issue, the doctors have consensus based on the comprehensive consideration of the clinical benefits and reduce the unnecessary exposure to the virus. The AAC statement for COVID-19 highlights the need to avoid performing inappropriate exam. I guess if in the future robots can do the exam in the isolation wards, the ultrasound will be routinely. That will be awesome. Thank you.
Thank you for answering the question. That's great. I agree with you. Thank you. Next one.
Okay, the next one question is about Dr. Fei Xiang's presentation, and the question is, how do provider determines what the PPE to put up prior to the entry into the contaminated area, And is the scanning area further subdivided into the normal area and the pure area? So would you could you give us some opinion about these questions, Dr. Fei, please? Oh, Dr. Fei, your manual, I can't hear you.
Okay, I'm so sorry. Okay, can you hear me clearly?
Yeah, yes.
Okay,
Please.
and thank you for your very good question. So before entering the contaminated area, the doctors can decide on PP according to whether the patient is infected with the novel coronavirus or not. If the patient is an ordinary patient, I mean, not in the affected area, not in close contact with the infected persons, so I suggest the doctors use primary protection. That is okay and enough. So if patient is suspected or of infection, or the patient closely contacts with confirmed patient, so I suggest the doctor should use secondary protection. If the patient is diagnosed with NCP, tertiary protection is required. This is very important. So I agree with your suggestion on the division of ultrasound scanning area. It's true, the scanning area should be further divided according to whether the patient is infected with the novel coronavirus. So in our hospital, if a patient meets a diagnostic criteria for suspicious cases described in the 2019 novel corona issues by our country, he or she is referred to a specialized screening area for the ultrasound examination. That is my opinion. That's all. Thank you.
Okay, thank you. Definitely, the protect protocol is really important for all of the healthcare workers. And only do this better, we can get more safety situation. So yeah. Thank you very much. Thank you. And let's go ahead. Next questions. Dr. Fei, please.
Okay, thank you.
Okay.
Let's go into the question number 12. The question is, can ultrasound diagnosis of novel coronavirus pneumonia patient with lung diseases? So I think this question, I would like to invite the doctors who from the Wuhan hospital, the Dr. Li Yuan and the Dr. Qingzhou. And would you give us some answers to this question together? So firstly, I would invite the Dr. Li Yuan. You please. Thank you.
Yes. I think the question, it depends. In my presentation, I showed some typical signs of in non-ultrasound in the coronavirus 19 diagnosis. So firstly, when we scan the patients, we need to check the lung regions, 12 regions, one by one. Especially in the early stage and the lesions located in the subpleural, I think it's much easier for us to detect. But when it goes through to the advanced stage and the lesions located in the central part of the lungs, I think it's hard for us to detect the lesions. The lung ultrasound, so it cannot use in place of X-rays and the CT scans, but it can give us more usage in the monitoring of the patients, especially in neonates and chronic disease and ICU patients. For reduce the cumulative radiation doses. That's all. Thank you.
Okay, thank you, Dr. Li Yuan, for sharing your experience and answers about this question. So next, I would like to invite the Professor Qingzhou. Could you give us some additional opinion about this question? You please. Thank you.
Okay, first I agree with the opinion of Yuan Li. I add some some more. So I think the more we know about the COVID-19 and the long ultrasound, the more I think long ultrasound should be used in COVID-19. I think there are definitely some specific signs for interstitial peripheral pneumonia on long ultrasound. And if you grasp these signs and this period, it means COVID pneumonia. So this is the value. The second point is that the long ultrasound should be used, very convenient to use to follow up the long lesions, because in critical unit for the patients, they cannot do CT every day. So this is my opinion. Thank you.
Okay, thank you. Thank you, Dr. Qingzhou and Yuanli, for sharing a very useful and valuable experience from your work. Thanks again. Okay, let's move on to the next question. Professor Wei Zhang, you please.
Yeah, okay. I see the time is limited, and can we have the 10 more minutes for the last one questions? So, okay. last one questions about in which cases can ultrasound be used? So this question isn't really common. So I think Professor Li Yuan can answer these questions about.
Many thanks. I think ultrasound is so convenient and free radiation, so it's suitable for multiple organ detection. Because this disease can attack multiple organs in the of the patients. But we need to do the ultrasound as focused as necessary. I think in this COVID-19 pandemics, so for protect our doctors and especially we need to, for example, for the long ultrasound may be more useful in the ICU patients disease monitoring, yeah, to reduce the radiation. Thank you.
Okay, definitely. So I think the ultrasound maybe not don't have the more advantage during the diagnosis the formal lungs. So I think sometimes maybe for the multi-organ, when the patient infects COVID-19 in the ICU. So I think the ultrasound can play the different function or different role during all the treatment of the patients. So thank you very much. And today we already go over all of the sections. So Dr. Fei, please give us the.
Okay, thank you, Professor Wei Zhang. Okay, today's topic, the COVID-19 meets ultrasound, I think has aroused wide interesting. So unfortunately, our conference time is limited. So we will collect all the questions and prepare the answers and list all the answers to the AIUM COVID-19 section. And please log in the AIUM website and you can find the answers to all the questions. And thank you. That's all the section, discussion section. And thanks all the speakers and the presentation. Thank you, the Professor Jing Gao, and thank you, Professor Wei Zhang. Okay.
So the last one, I'd like to invite Professor Brian give us the close market. So, Dr. Brian, are you here?
Yes, so I want to thank everyone, all the presenters, all of the people who worked on this project. This has been an amazing opportunity for us to get together and hear what has transpired in China, and for us to learn all of the things that you discovered being the very first people who had to face this epidemic. So we thank you for the time that you put in, and we hope to be able to continue our interaction with the Chinese Ultrasound Doctors Association. And so on behalf of the AIUM, thank you very much for all your work.
Okay. Thank you, Professor Brand, and everybody. Thank you very much.
Thank you, everyone.
Okay, thank you, Professor Brand and Jing Gao.
See you again.
Thank you.
Professor Brand.
Thank you.
Thanks for participating. Have a nice weekend. See you and bye.
Thank you, everyone. Have a nice weekend. Bye.
Bye.